Welcome to everybody. It's a pleasure to have you on board for this fifth step of our PCR webinar on the road. This time, we travel to Verona, and we have with us Professor Flavio Ribichini, and we will talk about patients with severe aortic stenosis and coronary artery disease, how to treat them. We, as usual, always move from general concept of the guidelines and papers into real clinical practice. This time, for the first time, you can follow this webinar on Facebook and Twitter, but you can claim your credits on PCR online, and you can discover with us the objective of today, and I will give the word to my colleague Dejan to go through them.
Hello, everyone. As Chiara nicely said, it is a very interesting topic. She also said we are joined today by Professor Ribichini, to whom we virtually travel to Verona. And Professor Ribichini has a lot of experience with what are the questions for today. So our question is, if we want to perform PCI in a patient who is planned for TAVI, when should we do it and why should we do it? How do we evaluate coronary artery disease in a broader sense in a patient with a severe aortic stenosis? And once we decide for placing a stent into a patient who has a planned TAVI, how do we proceed with antithrombotic therapy?
Hello. Hello, friends. Hello from Verona, from this beautiful city. And thank you, Chiara and Dejan, for the invitation to be here with you. Very briefly, for those who don't know, Verona is a city, it's a Roman city in the northeast of Italy, in between Milan and Venice. And our hospital, it's a big university hospital. I am the chairman of the cardiovascular department. And we are, as all of you, dedicated to the treatment of this new population of all patients with aortic stenosis. And sometimes, it is not infrequent, nearly half of these patients do have concomitant coronary artery disease. So this is why we are here today. We have developed a quite nice experience on the treatment based on the question, should we treat or should we not treat the coronaries in these patients coming with symptoms of severe aortic stenosis? The finding of the stenosis in the coronary most of the time is just by chance. So the treatment should be considered very thoughtfully. And this is why we are here today.
Thank you very much, Professor Ribichini. So can we start with the first case already? I think it's, you have prepared some very interesting cases. So let us right away start with the specific case that you have.
Okay, please show me the first slide. And we start with an old female, 83. She has a known history of aortic stenosis, symptomatic for angina, but she refused the intervention until she had an episode of typical chest pain, and she went to a small spoke hospital of our province. And she had indeed signs of heart failure because of an anterior ST elevation MI. She was immediately transported to our hub center. This is the X-ray. You can see that she has a clear hemodynamic impairment. The ECG shows a tachycardia. She was given diuretics, inotropes, dual antiplatelet therapy, and non-invasive ventilation. She stabilized a little bit. This is the echocardiogram, shows a very hypertrophic, concentrical hypertrophic LV with moderate impairment of the function and a very high gradient. The peak gradient is near 100 millimeters of mercury. And while we were discussing on the heart team whether to operate, whether to go percutaneous, and we were trying to stabilize her clinically, she developed chest pain, again ST elevation, and hemodynamic drops. So in the night, the emergency team came to perform a coronary angiogram, which has not been performed before. And what you see is very clear. A large dominant right with a mid stenosis at the mid segment and a clear tight stenosis of the proximal LAD and the ostium of the left main. Fortunately, the vessel was opened, so we have the chance to decide how to proceed.
Well, it's a really, really interesting case to start our visit in Verona. And so we have a patient with ostial left main stenosis, first step. she developed cardiogenic shock, and she had even severe aortic stenosis. So what do we have to treat? The coronary, the aortic valve, both, and how? So which is your practical use in this case?
Well, I started saying that most of the time coronary stenosis are found by chance. Okay? The patient comes to your observation because of the symptoms of aortic stenosis. You do in your workup studies coronary angiogram and you find the stenosis. This is totally different. We know the patient has stenosis in the aortic stenosis, but she comes with unstable coronary syndrome. First, she had an aborted ST elevation MI, and then she had a second ST elevation MI. So you have to treat the patient for the reason he comes to your observation. And she came because of anterior MI. So absolutely, in this case of concomitant aortic, valve, and coronary stenosis, we have to treat the unstable one. And the unstable one is the left coronary syndrome system.
One question in that regard. So did you feel clinically that this patient was also deteriorating in terms of the pressure, so going to the cardiogenic shock, primarily because of the coronary artery disease, because of the acute coronary artery disease, or was it a combination of acute coronary syndrome and the fact that this patient had this severe aortic stenosis? Because on the angio that you showed, I did not see a thrombotic lesion, for example. There was a tight lesion of the ostial left main. There was extensive disease in the proximal LAD as well. But there was no, as you already said, there was no occlusion. So all vessels were patent. So did you think that this nevertheless had to be kept in mind, that this is, even though it's a combination, you said acute coronary syndrome first, but we should not forget about aortic stenosis?
Absolutely. The combination of the two things is lethal. In this woman, I mean, she was still alive because the left main was open. And so we had the time to put her on the table and to fix the coronaries to improve the flow. But the two things are really very, very severe. As I said, being a clear unstable coronary plaque, because she had an aborted anterior MI 1 week before and a second recurrence, despite dual antiplatelet therapy, you have to fix a coronary.
Okay, I have to tell you that you have support in the chat box, because several of our colleagues, Ahmed, Jorge, had already voted for PCI first. So let us see what you did.
Well, this is what we did in the emergency. Remember that. We will see different cases later. Well, my colleague on call put the patient on very mild, I would say shy hemodynamic support as a balloon pump, but it's better than nothing. And you are not too aggressive with the iliacs, thinking that you will lead the vessel for the TAVI, probably, if she survives. And then he proceeds with a straightforward PCI from the femoral. And you see that there is a balloon dilatation of the left main and stent implantation. You will see there is a second wire in the sinus of Valsalva, in the left sinus, and this is to make sure that you are not protruding too much with the stent in the sinus of Valsalva. We will talk about this if you want later. And the second stent on the proximal LAD stenosis. The final result is quite good. You can see that the flow is restored. The TIMI3 flow, there are no tight stenosis. Of course, she is still tachycardic and the ST is there. She will need some help to get out of this hemodynamic impairment because she still has severe aortic stenosis.
Yes, this is the reason that I wanted to ask if when you perform, in this case, an ACS left main PCI, if you can use the EABP to support without impact the valve, and if you do it routinely, and above all, even if you use the guide wire in the sinus always for left main ostial stenosis.
Okay, well, no, we very hardly use balloon pump. This was an attempt to see how she was doing. She started doing well hemodynamically after the PCI. and the balloon pump. So we didn't need to upgrade with more effective but aggressive mechanical support or with an emergency balloon valvuloplasty or valve implantation in the aorta. Because at that point, we didn't know anything about the size of the annulus, the calcification. So that was done blinded, and she did fairly well with the PCI and the balloon pump and hynotrops. Regarding the wire in the left coronary sinus, no, I never do that. That was a colleague of mine. I think it might be a useful trick if you are not very expert on stenting ostial lesions. And in this case, it's important how you put the stent if you are planning to put a valve afterwards.
Well, so how did you proceed in this patient? Since I can understand that you did not put a valve because you did not have any sizing for this patient. So not a balloon valvuloplasty, because in this unstable scenario, you didn't want to unstabilize more, maybe with a aortic regurgitation after the valve. So what happened to this patient next?
Okay, Chiara, what you said is very important. In case you don't get good pressure and good hemodynamics after the PCI, you might consider a balloon valvuloplasty with the risk you mentioned of developing a severe aortic regurgitation, which is actually not frequent, but it's possible. So you have to balance in your mind the potential benefit and the possible risk. So let's go to the slide so we see the end of this case, hoping it will be a happy end. I saw you before the sizing of the valve, what we did in the days after, because the patient had acute kidney injury after the hypotension and the contrast. So we wait a little bit to do the CT scan. She stabilized hemodynamically, and she implanted a 23 balloon expandable valve through a totally percutaneous approach, as you can see on the right picture, through the iliac arteries. Look at the difference of the ACG the day after the TAVI. She gets much better in terms of hemodynamics, with lowering heart rate and improving the repolarization in the anterior wall. This is the echo after the TAVI. There is not an immediate recovery of the anterior wall, but the hemodynamic result of the valve is good. The mean gradient is 6.7, and the patient was discharged. 2 months later, she came to a routine control with a totally normalized LV function and a residual mean gradient of 10 millimeters of mercury. She is doing very well after 1.5 years of this procedure. And I can tell you, because she is the sister of a colleague of ours, and so I came to know very, very recently about her very good style of living in this month.
Thank you for this. So we have from the chat box several different comments which I think are worth discussing. We have time for that. The first is something which Chiara already mentioned, and by Dr. Mansour, and this was actually also my question. In this specific case, did you think, because after finishing the left main PCI, the patient definitely did not stabilize completely. This is something which we got as a message from you. So why didn't you not consider balloon valvuloplasty at that time? Did you consider the risk of aortic regurgitation as too high and the patient well enough to so that she can wait for TAVI? What was your thinking there?
I will be totally sincere, because what we are showing is real life, okay? You perform the PCI, the patient feels better because has no more chest pain. The hemodynamics improves a little bit, and she has a balloon pump. She's still under hynotropic stimulation. You wait for half an hour, and things are stable. So you can decide to stop. At this point, there is, let's say, a crossroad. This guy who performed the case is not a TAVI implanter. So he didn't, let's say, continue with so far unnecessary, more aggressive treatment. If you are a TAVI implanter and you feel comfortable to manage with an eventual complication of balloon valvuloplasty and your nurse is ready, this case was done in the heart of the night, and you have a nurse who is able to crimp a valve, as we have in Verona, then you can proceed. But of course, your procedural risk is higher. I think that what he did was very wise. He waited until he evaluated the good hemodynamic status of the lady, and put her again in the intensive care unit. And it was okay because she developed acute kidney injury. She was hypertensive. We wait for a week until we could do the CT scan and we measured the right valve to do a procedure which was at that point elective.
Okay, so I think these are important messages for the people who asked in the chat box. So it was 7 days between the two procedures, which allowed also for the kidney function recovering a bit, and which also allowed for a meticulous planning of the TAVI procedure. The next idea coming from the chat box was this, and please comment on that and what were you thinking about that. So if you initially could have perhaps performed TAVI with the chimney technique, protecting the left main and so solving both issues at once. What is your opinion on that?
We do this regularly, Dejan, in elective cases. We are talking about an old lady on the table, hypotensive, tachycardic, anuric, under hinotrops, okay, in the night, when the emergency team is done by one interventional cardiologist, one nurse, and one technician. You are not in the best conditions to do a chimney with TAVI, things we will see in the next cases. But here we are talking about acute coronary syndromes in concomitant severe aortic stenosis. This is not an elective situation.
Great, great. Okay.
You have to take the patient first, then we can think about details.
Great. Chiara, do you have any questions?
No, I think that we can just summarize this case with the learning points that Professor Ribichini left us with if you can show the next slide, please. Next one. Just to say that for the outcome of our patient, we cannot improve the ACS or the severe aortic stenosis, but we can support our procedure, above all the PCI, with hemodynamic support, that if we have a left main PCI in an ACS, we are quite obliged to treat the ACS pre-TAVI, and that then we can treat the aortic stenosis, of course, if we are not TAVI implanter with a balloon, without a balloon valvuloplasty, but otherwise putting a valve in a safe manner after 1 week, waiting for recovery and improving the long-term outcomes of this patient. But if we do not have an ACS, what do we have to do? You anticipated something about the next case, so we can move on.
Well, I want us to start with a case doing what everybody does, because this is the way most people work. In this case, as I said, was a need. It was an emergency, and you have to treat the reason why the patient comes. And this is an acute coronary syndrome. Let's go to the next case, and we see what we regularly do in elective cases. The next slide, please. This is, again, an elderly woman, 80 years old, hypertensive, dyslipidemic with severe aortic stenosis, mean gradient of 55 with normal ejection fraction, with moderate renal insufficiency, symptomatic for dyspnea, but she had never complained chest pain. This is the coronary angiogram performed minutes before the TAVI. We do not do coronary angiograms before. We put the patient on the table and we start with the diagnostic coronary angiogram. And what you can see, it's a lot of calcium in the mitral annulus, a lot of calcium in the aortic valve, and a lot of calcium also in the proximal LAD. So the question is, would you treat this LAD before doing the TAVI or after doing the TAVI? What do you think?
Well, for me, the real question is why didn't you put the stent in the LAD and then move on to TAVI procedure above all? I don't know if, knowing your center, if you think that even in this potentially severe calcified but focal lesion, proximal, I would say, you think that it might be useful to use some IVUS OCT evaluation of this plaque, or rather a physiological assessment of this plaque?
Well, okay, I am a little bit older than you, Chiara, and I would say and I will make the question to you. Do you regularly put a stent in an old lady without angina just because you find a stenosis? Is that what you do?
Sometimes, in my experience, if you do it just before TAVI, probably it will be a useless stent, but the angio-guided angioplasty is something that I have really experienced. So probably I would have put a stent before.
Well, I think that you must have at least one reason to do that. Patient is 80. She's not a marathon runner, of course. She has never felt angina despite the hypertrophy of the left ventricle because of the aortic stenosis, and the lesion is tight. I agree with you. I personally need a reason to put the stent, not just because there is a stenosis or because she has an aortic stenosis. So let's see what we did. Go to the slide, please. You asked me about the imaging. I think there is a lot of calcium there. Putting a wire is much easier. And guess what? Look at the result of this physiologic interrogation. I mean, the lesion measured by both hyperemic and non-hyperemic indexes is really borderline. It's borderline with IFR and it's negative with FFR. But this is before putting the valve. If we have time, we can talk. I mean, this is not the condition the patient would leave with after we discharge. She would leave with the valve. And it might be that the severity of the lesion changes after you put the valve. And indeed, the IFR gets a little bit worse, but not that impressive, and the FFR remains normal. So at that point, do you think still that it's necessary to implant a stent, Chiara, with this physiologic assessment?
Well, believing in FFR, I must say that doing the physiological assessment, I wouldn't have put a stent in this patient. But the other point that maybe I will consider is that before implanting the valve, it's easier to get the ostium of the left main, and so to put a stent in the LAD. So this could maybe influence my choice of the valve to put in this lady, or maybe I will say, and if it changes after the valve, it was not the case, but you know, we read a lot papers, literature, and we cannot find out the real point connecting everything and telling us believe in FFR before and after aortic stenosis treatment, believe in IFR. So what do we have to do, really? We are starting to improve and to not put useless stent, but what do we have to believe? In your experience, can you teach us, please?
Okay, you have to believe on the patient.
Well.
And if the patient has no angina and is not a diabetic, this lesion causes no ischemia. And this was shown by the FFR and the borderline of the IFR. But as this case was done many years ago, we were still not so convinced of that because it's still a proximal LAD, it's still a tight stenosis, it's still a very calcified one. So what we did is what you can see in the next slide that helped us to perform another nice publication. We did an adenosine SPECT 3 months later, and as you can see, this perfectly confirms the negative findings of physiology. So the patient never had angina, and during 5 years of survival, she had totally normal style of living and no ischemia and no angina. So at that point, we can say that stent would have been useless. You don't know, you may have complications while doing the PCI. You put the patient on dual antiplatelet therapy for longer time, and it might still be that if after years of living without aortic stenosis, the patient comes with clear symptoms of angina, you can still perform your PCI after 3 or 4 years. And your renal function gets better, the patient is fit because she has been moving, and your LV function has improved because there is no aortic stenosis any longer. So the fact of performing a preventive revasc in totally asymptomatic patients without clear indications, without clear evidence of inducible ischemia, on my opinion, is not good. And according to the very few data we have, it's clear that there is no clear benefit of this preventive revascularization. The activation trial performed by Simon Redwood was published a few months ago. It's a small trial. They struggle to enroll patients. It's not clear, but what you see is that there is absolutely no trend of an advantage of patients performing unnecessary, I would say, not indicated by symptoms or clear signs of ischemia before treating the aortic stenosis.
Professor Ribichini, since we have plenty of time for discussion, let me try to address several lines of questions that we have gotten through the chat box and we also had related to this case. The first line of questions has been addressed by you and Chiara in your conversation about the fact that we have what it looks like angiographically severe lesion in a patient without chest pain, but with the symptoms of dyspnea and a diagnosed severe aortic stenosis that will undergo TAVI. So the question is, if we have the same patient without aortic stenosis, what would have we done? There is, as of now, no real evidence that in chronic coronary syndromes, implanting stents would be beneficial in every patient. So if we draw a parallel, if we try to think analogously, then your proceeding would be, I think, also appropriate. Now the question is, your decision-making was, however, done with a further step. You performed coronary physiology. And you performed FFR and IFR. I believe this was because this patient was part of a research project. I would then ask you, do you always perform both FFR and IFR? If not, which is the index that you would prefer, or do you use them interchangingly? Do you see any differences when using FFR or IFR for evaluating the severity of coronary lesions prior to TAVI?
Okay, very good points. Yeah, I like that you underline the point that in a asymptomatic patient or a stable patient with chronic ischemia and aortic stenosis, medical therapy offers the same outcomes compared to revascularization, either surgery or PCI. This is clear at least at 5 years.
Exactly. Which is an important point in an old patient. Yeah, this is an old patient, so having, I think, 3 years follow-up for ischemia trial, median of 3 years, offers us some time in a patient like this. Also, before you get to the question of FFR and IFR, one of the questions that I think needs to also be clearly stated here is the following. This is, even though it's a focal lesion, it does not look like a simple lesion. It looks like very calcified lesion. So does this play some sort of a rationale, or does this play into your decision to leave it for now, or is it irrelevant for you, the complexity of the lesion?
I have prepared the third case of the webinar to answer your question. I can anticipate that anything you do in a coronary with a complex lesion will be safer if the patient has no aortic stenosis. Okay. And I have already anticipated my thought for elective cases.
Okay.
Coming to the decision whether to use hyperemic or non-hyperemic indexes, there has been a lot of discussion on that. And we have done several papers on this, because the first argument is that aortic stenosis, because of the high end-diastolic pressure, because of the hypertrophy, because of the microvascular dysfunction, will not be able to induce hyperemia when you give adenosine. And as a consequence, your FFR will underestimate your lesion. Well, this is all theoretically possible, but in our own experience, and we have published this, we have shown that the PDPA value, which is just the difference of pressure distal and proximal to the lesion, does changes when you give intracoronary adenosine. And this means only one thing, that the microcirculation responds to further vasodilation. It's true that the hypertrophic heart has already some degree of distal microvascular vasodilation, but you can induce more. So the FFR is reliable. Then we did a study comparing the FFR values and the scintigraphy with adenosine, and we found a perfect correlation with the 0.75 cutoff. So we do believe on FFR after valve replacement. Regarding the IFR, also the IFR is very nice index, but it's much more variable if you keep the 0.89 cutoff, which is used for coronary artery disease. We have seen and published that the 0.89 cutoff does not correlate with the 0.17 in the aortic stenosis, but it's very close to the FFR. It's about 17.80. If you use 0.80, then you have the same information with either hyperemic or non-hyperemic value. Just think about cutoff, which is not the same for IFR for patients with severe aortic stenosis.
Coming back to what you said and to make it practical, if I'm to use IFR in order to judge the issue of the severity of coronary artery lesions prior to TAVI, and if I use the cutoff of 0.89, do I expect to have more patients being seen as significant, having significant lesions, as opposed to using FFR and the cutoff of 0.80?
You got the point. You got the point. Actually, we are running a multi-century nationwide study in Italy involving 13 of the highest volume TAVI performers in Italy. The study is called TAVI, and it's registered in clinical trials. And it's exactly a physiologically guided versus angiographically guided revascularization in patients undergoing TAVI. And after a lot of discussion, we decided to keep the FFR cutoff because we found it was easier to defer treatment than using the IFR. Because as I said, if you keep with the 0.89, you have a lot of positive results. If you use something like 0.79, 75 cutoff for IFR, you have exactly the same results that you have with FFR. So have a look at the TAVI trial. We hope we will be able to finalize enrollment next year, and a year later we will hopefully publish this interesting data on angio-guided versus physio-guided revasc in stable patients with severe aortic stenosis.
So now a question for Chiara and then for yourself. Chiara, if you would have this similar case, would you perform in your everyday practice, now convinced by what Professor Ribichini said, the FFR or IFR, would you do it before or after TAVI?
Well, absolutely. Now I think I'm convinced to perform the evaluation with FFR after TAVI. And then I will decide if it's the case to put or not a stent in this severe calcified proximal lesion of the LAD. So thank you.
Okay. Yes, but maybe one question to finish off this segment before we enter the final segment. We still have time. Is there something, because there are questions and there are now studies going on with a new concept of drug-coated balloons. So do you see any place, maybe not in such calcific lesions like here, that would be the middle way between these two approaches? Because even though if this patient was uneventful during 5 years, you seem to have gotten the right decision. However, this still seems to be a tight angiographic lesion. So if you ask me, I would rather like patients not to have such a tight lesions than to have them. Of course, if we try to avoid the metal and still treat the lesion, would you see a place for drug-coating balloons in such settings or not?
Well, what you are questioning is the ischemia trial. You can wait until the patient does not respond to medical therapy and treat her with a PCI, or in case she becomes an unstable coronary syndrome, you must treat her. Then the decision in between a drug-eluting stent or a drug-eluting balloon, well, in a case like this, very calcified, very tight, sincerely, I put a very short 12 millimeter 3.5 stent after good vessel preparation with either scoring balloons, cutting balloons, rota, or IVL, rather than using a drug-eluting balloon in this case. if you have long lesions, diffuse disease, small vessels, I do love drug-eluting balloons. But I think this is a super case for a 12 millimeter 3.5 drug-eluting stent.
I will be just a little bit provocative, just asking you. So you put a stent, because with the drug-eluting balloon, we can reduce the timing of DAPT. So
yeah.
Which stent you would choose in order to reduce maybe the time of dual antiplatelet therapy, because we know that now after TAVI, aspirin alone is good enough, and we can prevent bleeding. As you told us from the activation trial, we know that PCI, more TAVI, more bleeding. So
absolutely, Chiara. I would select a stent with a good radial force in this calcified lesion, and now we have stents that are accepted for short DAPT, 1 month. So I don't want to mention brands, but we know that there are some studies giving quite reliable experience to shorten the DAPT to 1 month in a stable patient. And she was absolutely asymptomatic. So it's the case to stay on 1 month of DAPT.
Okay, thank you very much. Thank you very much for this. I think that we can then move on and show the slides to wrap up these two cases. So basically, these are the slides, and I would actually like you to tell us this, because this is something which is basically the wrap-up of all the research that you have done in this field, which is really extensive. So how is it that you do it in everyday practice? And I think it's nicely seen on this slide.
Well, unfortunately, the first statement that we put there, you copied from our paper, but does not apply to this case, because it's an FFR, it's almost borderline, was 86, and normally they become positive. 86 is not really borderline, it's negative, and it remains negative. But it happens that when it is 80, 82, it drops when you increase the flow after removing the aortic stenosis. But the important message is that the real FFR value that you have to consider is that after you remove the aortic stenosis, because is the condition the patient will live with for the next years. And so that's my answer. Now we don't do before and after, except if we're doing a live case demonstration or the patient is in a trial. Now what we do is rely on the post-TAVI result.
Okay, thank you. So let us finish this, I would say, difficult part, the middle part, what to do with patients who are chronic coronary syndromes who present basically with aortic stenosis that needs TAVI. So please put us the final two slides of this segment. And this is basically something which may summarize what we have been talking about. The problem is the following, that we try to understand how to utilize our knowledge in coronary physiology that we have in stable patients in chronic coronary syndromes with the addition of aortic stenosis. And this field, at least in my opinion, is evolving, and the literature that is growing is still not huge. So we do not have thousands of patients in this kind of a setting. So basically the initial problem is that you basically have something which is like a serial stenosis. So the epicardial stenosis, which is number 2 here, is preceded by the aortic stenosis, which is more proximal. So basically there is flow impedance already at the level of the aorta, and then there is the impediment of the flow at the level of the epicardial vessels, and then lastly you have something which is at least an altered coronary microcirculatory function in patients with severe aortic stenosis. So what is known from the literature, what you can read in the literature, even though the case series are not particularly large, and I think from Professor Ribichini, something like 150 patients is the largest that I've read, at least myself. And what you can see as some sort of consistency is that the baseline flow, the baseline coronary flow, doesn't appear to change very much after you treat the aortic stenosis with TAVI, that the hyperemic flow appears to rise at least a bit, which gives rise to the CFR, to the coronary flow reserve as well. translated into what we as clinicians need to know, and the indices that are recognized as something as part of decision-making, FFR and IFR, it means that IFR may not change a lot because the baseline flow, at least in the part of the diastole, remains constant, and that the FFR may drop. On the case that we just saw, this did not happen. And also the literature is also conflicting. So I think that the knowledge here will grow. What Professor Ribichini says, and what may be a clinically and practically important message, is if we have borderline FFR prior to TAVI, this may change after TAVI. I think he was clear in saying that he would first implant the aortic valve and then evaluate the coronary artery stenosis. This is, of course, maybe controversial because then if stenting is needed, it will have to be done at the background of the valve. We will talk about this next. What is important to be seen now is the summary of the two cases that we need to differentiate very clearly. First, it was an ACS patient, a patient presenting with acute coronary syndromes and cardiogenic shock, in whom PCI was chosen to be first treatment, and then TAVI after a few days, a planned TAVI after a few days, which allowed for a nice preparation with the CT scan and for the accurate valve placement, and which avoided the risks of balloon valvuloplasty, like a huge aortic regurgitation, which would have endangered the patient. On the right-hand side of the slide, you see the second case, and this is totally different kind of a patient. It's a patient presented with dyspnea without any chest pain, so we consider him to be a chronic coronary syndrome. In this very patient, what the team in Verona opted for was a coronary physiological evaluation of the lesion, and following basically what we know from coronary syndromes, from chronic coronary syndromes without aortic stenosis, medical treatment. In this particular patient, this was a successful strategy with 5 years without any event. This being said, these are the variables that are going to impact the prognosis of the second patient. So the coronary physiology utilization to defer treatment of the coronary stenosis and treatment of the aortic stenosis, which is depicted in green, because we have evidence that the treatment of aortic disease in this patient will improve prognosis. We do not have definitive evidence what to do with the coronaries in that case, and I hope that our discussion portrayed the dilemmas that we may have in this field and also showed the way that Professor Ribichini and the team in Verona see this. So now I would like to ask Professor Ribichini, we have 10 minutes to show our next patient and to introduce to us his concept of treatment of patients with concomitant coronary artery disease and aortic stenosis.
Okay, I think now that you are mature to understand the third case, because of course this will raise a lot of discussion, and I do it on purpose. I want to be provocative because at this time of the day, if I don't provoke you, you will turn the screen off or fall asleep. So please show me the next slide, and we showed you the next patient, which is my favorite, 76. So this is younger, he's a male. It's a very fit man, but with a normal heart and a normal renal function in sinus rhythm, with RBB, but with a severe vascular disease. You see that he had carotid endarterectomy bilaterally in the past, and a recent Doppler showed that one of these operated carotids on the left was totally occluded. Then we found that also the subclavian artery, including the vertebral artery, was totally occluded. He has a severe aortic stenosis, symptomatic for angina, class 2, which was worsening to class 3, also accompanied by important dyspnea in class 2. But he has been doing worse and worse in the last 6 months. He was sent from other region to our center. We did the CT scan. You can see the extensive vascular calcification at the iliofemoral level, and most notably on the supraaortic tracts. You can see a porcelain aorta on the left picture. You can see the totally occluded left carotid artery on the left picture, the totally calcified subclavian artery on the right part of the picture. Then you can see a totally occluded carotid again, and a massive calcification of the left main, the LAD, and the bifurcation to the circumflex. Then you can see also in the vertical line the calcium going down the mitral aortic junction to the anterior leaflet of the mitral valve. So this is the diagnostic catheter that shows you the difficult use of the catheter through the supraortic trunk. Then the colleague went femoral, and you can see a totally occluded, very small minor right coronary artery and a big left system providing collaterals to the right and showing, with no doubt, a tight stenosis of the left main, which involves in a trifurcation, an intermediate branch, the ostium of the CERT and the ostium of the LAD. So this explains this patient is symptomatic for angina. He has been worsening, now is in class 3. So, Chiara, this patient is relatively young, he's 76. He has angina. He has severe aortic stenosis, multivessel disease involving the left main. It's at intermediate risk, and it has a lot of calcium with the circulation of the brain, living on only one vessel. Only one vessel is putting all the blood on his head. What would you do? A TAVI, PCI, or a surgical treatment?
Well, it's a real challenge indeed. Above all, because of the amount of calcium that you have everywhere. I will say that if you can check the femoral access, because it's the only one through which you can perform your TAVI procedure, probably this patient, considering the porcelain aorta and even all the calcium that the surgeon will find at the level of the LVOT and the annulus, well, I think I will consider this patient for TAVI. Absolutely, you have to choose the good valve, because we are not surgeons, but we are working as them in the aortic route. But probably I would have considered the protection of my only artery, the left one, and the TAVI procedure.
Okay. There is no doubt that a patient living with only one vessel, putting all the blood in the head, is not a good candidate for extracorporeal circulation. Then there is a porcelain aorta. And then another detail, which is not a minor detail, the subclavian is totally occluded, so you don't have left to do a good surgery. So there was no discussion with surgeons. They absolutely agree with that, despite the fact that before the guidelines released this summer, this 76 feet man would have gone to surgery in our center. Now the guidelines allow to treat with TAVI any patient who is older than 75. But in this case, there was no discussion for a TAVI. So let's go back to the presentation, because the next question is not simpler than this one. This is to you, Dejan. What would you do first? The TAVI or the left main?
Yes, that's a good question, which I think we have been preparing throughout the whole webinar. So if you analyze the questions from the chat box from the overall perspective, what people are often saying is, please fix the coronaries so that we do not have to worry about coronaries when treating the aortic stenosis with TAVI. So I think that most of our colleagues from the chat box would say, well, let us first take care of the left main, and then think about the aortic stenosis.
Okay, let's see what we do.
Let's see what you did, yes.
Let's go, please, back to the images. There is no need for no need for physiologic assessment. The patient has angina, and this left main, with no doubt, is very severe. And you have a totally occluded right that gets collateral circulation from the left. As you can see, we decided to implant a self-expandable Evolut R. What we did, using a pacemaker, what we normally don't do, we pace on the wire. But remember that the patient had right bundle band block. So at high risk of complete block, you don't want to have a total block without the pacemaker on the right ventricle, with a tight stenosis on the left main. So what we did was getting rid of the aortic stenosis, and then from the same femoral axis, going through the diamonds of the core valve, looking for the good hole. You find it. You say it's not perfectly selective, but this is not necessary, because when you advance your wires, the guiding catheter gives you great support because it sits on the struts of the valve. So even if you are not perfectly selective, the catheter stays there. I will not get into details of the bifurcation treatment because it's not the matter of our case, but you see a stent is going from the ostium of the left main to the proximal circ, and a second stent went from the ostium of the left main to the proximal LAD. You see a third wire protecting the intermediate branch that hopefully remain open. And on the right side of the picture, a final IVUS assessment that I'm not going to show you because it's not the issue, but just the final result, which is good after this culotte stenting technique and the closure of the cane. The patient did very well and was sent home. So we have 7 minutes to discuss this crazy idea of putting a core valve in front of a left main and then doing a complex PCR with 3 wires, culotte, and all that in a calcified left main. What do you think about that?
Well, indeed, I would like to start by telling that this is an amazing case, for more than someone a crazy case of treatment, because I don't think that all the TAVI implanter would survive to leave a left main, a trifurcation coronary stenosis after putting a valve. Then, second point, you chose the right valve for the calcium, but maybe the less comfortable valve for the re-access. We have data on this, and we know that, as you show, it was very easy to re-engage the left main. Indeed, I have to say that I followed your learning session with some real simulation at the London Valve, and I saw that you sorted out 3 main points that I would like just to show, because it's really, really important that we know how to face this valve in place without being scared. It was just nice seeing you re-engaging the left main with your catheter, and in this learning session you told us that we have to choose for the left main a catheter a little bit smaller than the one that we will use in a native anatomy without a valve, and that we can use our guide in order to have more support, and that if we did not use some tricks, as we showed, that can be the commissural alignment, we can easily move our guiding catheter anterior and posterior in order to find the right point not covered by the tabs in order to engage our left main. And it was absolutely amazing, and I will just add the point about this commissural alignment, because we don't have to be scared by the higher stent valve and supraannular valve, because if we use these tricks, we can easily re-engage the coronary ostia even when we have a supraannular valve, and we don't have to care about this because we will have in place our leaflet, and it will be as easier as when we re-engage coronary ostia with the valve, we can say easy to live with, like the low stent frame intraannular or the higher stent frame but intraannular valve. So I think these are the major points. But this is the real question that I think everybody will ask you. And so why do you really treat your patient in this way? Because it's amazing, it works, but which is your point of view indeed? Why in Verona you do like this?
The first point is safety. And the second message is treat the patient for the reason he's coming to you. when you see such a calcified annulus with the calcium going to the anterior leaflet of the mitral valve, we do prefer the sweet deployment of a self-expand balloon, and we avoid aggressive balloon expansion. We might be wrong, but we are a little bit shy on that point, and we don't want to see annular ruptures or things like that. But then you say, yeah, but you have a coronary, which is not a minor one, that you have to treat. Why don't you treat it before? I tell you, the third message is you are treating the patient because of the aortic stenosis. Then the coronary in this case is very important because it's not a mid LAD, it's the left main. Anything that happens in a patient with severe aortic stenosis, especially if he had impaired LV function, because of a complex procedure, you have not prepared well the calcium, the stent is not going, you have an occlusion of the LAD, a dissection of the left main, and you have a severe aortic stenosis, the patient may not survive this procedure because he has no capability of recovering hemodynamics because of the cork you have on the outflow tract of your LV. Get rid of this aortic stenosis, and it's still a challenging procedure, but it will become much safer. So if we can go to my last slide, I will show you why we do this in Verona, because any PCI, and especially high risk, is safer in patients without aortic stenosis. So we treat the aortic stenosis first, because in most patients, CAD is an occasional finding, and aortic stenosis is the problem you have to treat. Because when there is no clear indication of PCI, physiologic assessment of the lesion is better after you remove the aortic stenosis. This is not the case for this left main, but for the previous. And because we do not believe that having a core valve makes things impossible. It may be more difficult, but the result of this trial published by Marco Barbanti that shows a large number of cases where you cannot engage are not representative of our practice. On the other hand, you know always about the difficulties of going with a catheter after TAVI. We talk about that in webinars, in congresses. You publish this as a case report. So it's a very overstressed issue. You know nothing about the severe complications of performing PCI before TAVI, because these complications do not go into a registry because the patient does not read the TAVI table. So think about that. Don't do useless PCI. Change the valve and learn how to do the PCI through any kind of valve. That's my last message.
Thank you very much, Professor Ribichini. Just one minor question before concluding with the final slide. Do you also perform rotational atherectomy after you already had placed the TAVI?
I have a lot of fun doing that.
That's a good answer. It requires a separate webinar to show all that, and hopefully we can do that in the future. Thank you. So let us see the conclusion. Thank you everybody for joining. We basically saw 3 wonderful cases, and I think that Professor Ribichini made his point. That in the first case, because of the ACS causing the clinical deterioration, he did PCI first and then TAVI. In the second case, he weighed out his options and he opted for not stenting the lesion, the coronary lesion, but doing only TAVI, and it proved to be a valuable option. Uneventful during 5 years, and this was based on coronary physiology. Surely an involving field with a lot more data in the future. And then lastly, he showed how he performs TAVI first and then PCI, even if that PCI that's going to be happening is going to be a complex one. With that, I would like to conclude, to thank Chiara, thank Professor Ribichini, thank all of you for joining. I also would like to thank PCR Online for their support, and also to Concept Medical. I would like to ask everyone to join us in December once again, 23rd of December at 17 p.m. We will be going to be in Madrid with Professor Javier Escanet, and we are going to be talking about in-stent stenosis. What to do with it, how to treat it, and how to detect mechanisms by using intracoronary imaging. Thank you very much, and see you again.
Thank you. It was a pleasure to be your guest.
Goodbye. Thank you.
Bye.